This is Christy Fuller from Mountain Pacific Quality Health, and I want to thank everyone very much for joining our educational webinar this evening. The title of the webinar is Putting a Face on Patient Safety. We truly appreciate each of you taking time out of your very busy schedule to participate in this webinar. We will learn how patient stories can engage hospital board leadership in assuring that their hospital provides care that is safer, more reliable, and less costly. Mountain Pacific Quality Health is the quality improvement organization for Montana, Wyoming, Hawaii, and Alaska. And I'd like to give a huge thank you to Dr. Charles Denham, this evening's facilitator and presenter, for taking time to present and facilitate this session from Europe, I might add, and that's really going above and beyond, and we do appreciate it, as well as for arranging for our excellent guest speakers today. And those speakers are Dr. David Parda, System Chair of the Department of Radiology Oncology, Allegheny General Hospital and West Penn Allegheny Health System Radiation Oncology Network in Pittsburgh, Pennsylvania. We also have Dr. Gladstone McDowell. He's the Medical Director of Integrated Pain Solutions in Gahanna, Ohio. His areas of expertise include urology, anesthesiology, pain management, and safety. We also have Regina Holliday, and she is a Washington, D.C. based patient advocate and has a very compelling personal story to share. I want to thank, too, the co-sponsors of this webinar, the Montana Hospital Association, the Montana Performance Improvement Network, and Montana Hospital-Acquired Infection Prevention Initiative. Thank you to those organizations for helping to make this session possible. We have a very packed agenda for the next hour and a half, so we will do our very best to move quickly and to stay on schedule. And before I begin, I would like to mention just a couple housekeeping items. All of our participants' phones are muted and will remain on mute until the question and answer session. And at that time, if you have questions, you can ask them either electronically via the web browser, or we can take questions over the phone. Or I do believe also you can enter questions during the webinar into the question and answer portion, and we will answer them during the question and answer section. And at the conclusion of this presentation, there will be polling questions that come up on the screen. Please complete these questions as prompted by Nicole, who is our WebEx host. These polling questions give us feedback on how to improve our future educational programs. And at this time, I am pleased to introduce Mountain Pacific's Chief Medical Officer, Dr. Dwight Heasterman. He has spent 25 years as a practicing physician and more than a decade with Mountain Pacific Quality Health. And he's been the Chief Medical Officer for Mountain Pacific for the past year. Go ahead, Dr. Heasterman.
Thank you, Christy. And again, good afternoon and evening, and welcome to all our participants and to our speakers. And a good morning to Dr. Denham in Paris. I want to congratulate you for taking the time, as Christy said, to participate. Putting a face on patient safety is so important. I want to introduce Dr. Charles Denham. Dr. Denham is an international leader in patient safety and high-performance care solutions. He's taught and led research in medicine, engineering, and business leadership. He's involved in encouraging hospitals and healthcare organizations to dramatically improve patient safety and care performance. He co-chairs the United States-based National Quality Forum Group that annually updates the National Quality Forum endorsed safe practices for better health care. He chairs the Leapfrog Group Safe Practices Program. He's chairman of the Texas Medical Institute of Technology, which operates a national research organization which pursues its mission of saving lives, saving money, and building value in the communities served. He's a senior fellow at the Harvard Advanced Leadership Initiative and has a faculty appointment at the Harvard School of Public Health. He's editor-in-chief of the Journal of Patient Safety and a co-founder of the Global Patient Safety Forum. And just as an aside, Dr. Denham informed us that the Journal of Patient Safety in its December edition will publish articles surrounding the Partnership for Patients initiative including information on the vision and success stories of this initiative, and information on measures and standards for value-based purchasing. Dr. Denham has presented at a number of national conferences, and I think you'll find him and his speaking extremely engaging. Go ahead, Dr. Denham.
Well, thank you very much, sir, and I really, really appreciate it. This is a real honor to be with you, and just by way of explanation, I am in Paris, France, on kind of an extended number of meetings with hospital leadership teams, and we spent the last week at the WHO, at the World Health Organization, shooting the next a portion of video for our next Discovery Channel movie or documentary in patient safety, and it really is a pleasure to speak with you after spending time at WHO. I just want to let everyone know that the WHO is just launching a curriculum in the next 60 days for healthcare leaders, physicians, medical students, and nurses. That is an entirely updated curriculum that any and all can take advantage of over their website. So it's exciting to kind of see this global initiative. I've advanced my slide to the second slide, which is the Josie King story. Patient stories are absolutely critical, and I'm really, really honored to have Regina Holiday, our last speaker, is one of those patient champions who has had an event in her life in patient safety and now brings the positive energy of that experience to help all of us. And reliving her experience, she's one of those courageous leaders that you'll hear from that will talk about how she's channeled the energy of a harmful event that occurred in her family's life to the positive to help all of us. Sorrel King, on the slide that you see before you, tells Josie's story in a book that she wrote, and we produced a videotape after she initially told her story in 2002 regarding the loss of her 18-month-old Josie King. Sorrel told this story in front of an audience at the Institute for Healthcare Improvement. It was clearly a scary event for her. She was fresh after having this terrible event when a series of handoff #1 ranked hospitals in the world and in the United States it can have this kind of event befall it, and this is what happened, was that a series of handoff issues occurred, and this poor child was not given oral fluids after she was discontinued from her IV, and in front of all of these great physicians and nurses and doctors in training, despite her mom's request over and over again to evaluate Josie, she became 15% dehydrated, and then an unfortunate medication error killed her daughter in front of her eyes. And rather than channel that negative energy, she had to go through the Kubler-Ross stages of grief. I've put this slide before you because I think it's really critical that we all understand that it's absolutely vital that we bring patients and families into our infrastructures of our hospitals, because it connects the head and the heart. You'll hear in a few minutes, I'll talk about some of the books and references that help us understand how to make ideas really work, and that is to connect the head and the heart. But it's also important to address the fear that we have to invite these patients to come into our lives of our hospitals and tell their stories. And there are really two groups of patients and families and advocates. There's the A group, who are fresh after an accident that has occurred, and they're going through the Kubler-Ross stages of grief. You'll hear from Dr. Gladstone McDowell in a few minutes, and Dr. Dave Parda, both who have practiced as oncologists. Gladstone McDowell has practiced as a urologic oncologist, and I had the honor of practicing with him when I was a radiation oncologist, and Dr. Parda is a radiation oncologist in practice in Pennsylvania. We had to spend time, and I had to spend time helping patients and families go through these stages of the initial denial that this thing has happened in their lives, and then the anger, then they go through the bargaining stage, and then they go through a depression period, and then they come to acceptance. And I think it's really important that we all recognize we're not asking patients and families that are going through this grieving process where the catharsis of telling their story could actually do some damage in our organizations. And that's where a lot of fear of board members and the C-suite, CEOs, COOs, CFOs, and chief quality officers have for this. Once we know, however, that a patient or family member that may have had an experience, or a caregiver that hasn't even been involved in an experience, or patient champion really is channeling the positive energy and been through that process, I call that group the B group. They could be amazing contributors. And this story, the Josie King story, is one that we've had the honor of telling in the Journal for Patient Safety. This was mentioned just a little bit earlier. I'm the editor-in-chief, and this journal has agreed and allowed us to provide the articles that are written about patient safety accidents and areas of patient safety content that address that. If they address the National Quality Forum safe practices, they provide them free and over the web, and they're also offering a reduction in the cost to those of us that are focused on the Partnership for Patients going forward that's been announced by the Centers for Medicare and Medicaid. One such article is the article "Story Power: The Secret Weapon." I wrote that with Dennis Quaid and a nurse that has been through a terrible event and a death at her own hands of a 16-year-old young mother. Julie Tao was a nurse that was loved by all. The doctors picked her as somebody that they wanted their wife and their babies to be taken care of. And unfortunately, due to a number of system failures, simple human error and fatigue, she made that catastrophic mistake that any one of us would have when she took extra shifts to cover in her unit. They had a closed unit, and the decision had been made to create systems that would help the anesthesiologist put in the epidural lines and load the pumps, the medication delivery pumps, which Dr. McDowell may mention in a little bit, and the process was established to help the anesthesiologist streamline their work. Unfortunately, it set her up as a nurse who was fatigued to connect the wrong connector, which any one of us would have done between two IV bags. One was the proper bag that should have delivered the anesthetic to the epidural that was connected to an IV line. Any one of us could have had that happen, and that ended the life of a 16-year-old. Fortunately, the baby survived. We use these stories to actually help illustrate the great opportunities for leaders. In this article, the three of us established the power of stories, that every good story has a victim, a villain, a hero, a crisis, and a resolution. Dennis Quaid had a terrible accident occur to his twins in California, and has channeled that energy and telling that story of this near miss in 41 hours, a 41-hour vigil when his twins almost died, bleeding from every puncture site and likely having internal bleeding at great pain. And they went through this 41-hour vigil, and fortunately these twins lived. And Dennis has been working with us. He's folded his foundation into TMIT and working with us to tell these stories to help draw the attention to CEOs, COOs, CFOs, and board members and help them understand how we can use stories like this to help motivate our hearts and minds on the focus of what we need to do. No one comes to work as a caregiver intending to harm a patient. That's very, very, very rare. 95% of the harm in America today that occurs, the healthcare harm or the hospital accidents, are system failures. These are the lacking support systems or support systems that we just haven't developed that help accommodate for or help us with typical predictable human error. So this motivate the heart and the mind, and properly used, they can open the doorway and open the doors for the boards of directors to become more engaged in patient safety. They illustrate the areas where systems investments need to be undertaken. And most recently, the Partnership for Patients organized by the Centers for Medicare and Medicaid, and the wonderful program for the QIOs, which was established, and the 10th scope of work and the contracts for QIOs have actually emphasized the critical importance of bringing patients and families into the quality infrastructure. That's where I met Regina Holliday, who told a very compelling story, which you'll hear shortly. This article we recommend to be used by boards because it allows boards to understand and allows us to understand the blind spots that we have when we govern and operate healthcare organizations. It's so easy to just focus on finances and not focused on quality and safety. Our quality and safety officers have an unprecedented workload. We're learning just recently with the Office of the Inspector General report has found that we have 15,000 deaths in seniors. If you're a 65-year-old patient admitted with a medical diagnosis in America today, 2/3 of our patients that are over 65 that are admitted with a medical diagnosis, not for routine surgery or not for cosmetic surgery, but for heart disease or diabetes or another one of the medical illnesses that we can code in our coding systems, which are a huge number of admissions. 2/3 of those patients will be dead or readmitted with the same problem within a year. This is why the Centers for Medicare and Medicaid have put huge emphasis on readmissions and why payment is being tied to it. We infect 100,000 patients a year with infections that they didn't have when they came into the hospital. 100,000 of those patients die each year. Healthcare accidents and preventable harmful events have now achieved the status of being number 3, the third leading cause of death. As I move to infections, the second article that I put up here, and both of these articles are may be downloaded from our website at safetyleaders.org, www.safetyleaders.org, is an article that I wrote that ties the concept of infectious conditions that we give patients and this catastrophic thing that occurs with leadership. And it turns out that leadership is infectious as well, and that in our greatest organizations, hospital systems, I have the honor, one of the things that's not been updated in my bio is that I've been appointed a full professor of health services engineering at the Mayo Clinic, and we're understanding more and more that the sweet spot of high performance lies when our leaders are engaged, so engaged leaders, safe practices, and those that are enabled with technology. So in this article, I illustrate one of the methodologies used by the group, and I'm a political independent, but this was a professor at Harvard, taught us about social entrepreneurship and how the public narrative and stories were used in the Obama administration to galvanize grassroots efforts that could be used in healthcare organizations, and we use that as an example. The next slide is a slide that addresses if board members and non-clinical and clinical people, anyone wanted to really understand the nuts and bolts of storytelling. How do we tell stories? What is the design of the best story? The book written by Stephen Denning who was formerly an IT person, an IT person with the World Bank, realized that he was getting nowhere with his analytical charts and graphs and numbers as he was trying to galvanize his teams to get to work. He simply turned off the projector and began telling stories about the people whose lives could be affected by the World Bank IT approach. A leader becomes a leader is another example of how stories with facts and historical features of the personal stories of great leaders can have impact. These two are books that I recommend. The next two books, one by Outliers by Malcolm Gladwell, who tells stories that really help us understand, and in his earlier books have told us how the spread of ideas can have huge impact. And the book Made to Stick is by Chip Heath and Dan Heath, One is an educator, the other is a person in advertising, and it is the single best book that helps us understand the principles of great storytelling and how you can actually frame them. They use a memory tool called Success, SUCCES. The best stories that make ideas stick are simple, unexpected, credible, concrete, emotional stories. If there's an unexpected twist or turn in a story, it makes it memorable. And now you see in advertising that this is used all the time. In the movie that we developed for the Discovery Channel called Chasing Zero, we use 6 stories of patients and families who have experienced bad events to draw attention to the system failures that occur even in our best hospitals. And then we focus on role models that are doing a great job at developing those support systems. Rather than pointing the finger at the bad guy, let's point the finger at the 95% of systems failures that actually set our wonderful caregivers up to make predictable errors like Julie Tao did. And so Julie is in this movie. We provide this at zero cost and we've provided it to all the QIOs. We provide it to all hospitals nationally. And we've now developed a toolbox that tie the stories to actionable activities that hospital boards and leadership teams can take. We also have this streaming from our website. There's no cost at all. We wanted to reduce all barriers for access, and DVDs are made available for boards to actually use this for board retreats. September for release, it'll be on the global Discovery Channel. It's called Out of the Danger Zone, and it'll focus on this triad of leadership, practices, and technologies. I'll close by just sharing how these stories can have huge impact in some of the really important areas of great concern today for board members. It's absolutely critical that the C-suite, CEOs, CFOs, COOs, and Chief Quality Officers focus on the emerging stories and impact that could happen to any one of us. We do, in America today, we do 80 million, that's 80, not 80,000, but 80 million CT scans. At least 30% of the CT scans are overused. We use them out of convenience. 1 in 5 studies are done because we just can't find prior information. Quite often we do it out of convenience rather than defensive medicine when we can't find information. Primary care doctors would send somebody to a specialist. No one has access to really all of the data regarding the patient. And unfortunately, you see these pictures of the halo ring hair loss that has occurred when patients were overdosed by CT scans. It turns out that many of our states have no requirements for technologists to understand the technologies they use, and that the architecture of many of our CT scanners are not closed like an Apple PC. They're more like your PC that allows you to change settings, and they would try to optimize settings to get good studies and actually excessively overdose patients. There'll be more and more of these system failures that occur as we treat patients with complex illnesses. Now, what is a board member or a C-suite member to do with these events? It's critical that we bring this before our leadership teams and find out what is going on, what is the risk in our organization, and use stories and the stories of other organizations to actually have the impact. I'm going through a few slides just to give you a perspective of the fact that the media is going to use stories, and the media doesn't use them to the positive the way that you can. The 3 rules of the media are, if it bleeds, it leads. Never let the facts get between you and a good story. And a good story has contradiction, combat, and opposing forces in contradicting leaders. And so we're experts. So it's really key that we focus on leadership practices and technologies in our own organizations. Do the best job we possibly can, incorporating patients and families and the stories of other organizations and high performance. And as I close, the model that we recommend is it's critical that the leaders, the board members, and the C-suite are aware of performance gaps. They need to know where the accountability is for the change in behavior that must occur to close those gaps. They must invest in the ability of those. You can be aware and accountable, but unable, not have the ability that really is dark green dollars and light green dollars to make the impact. And then actions must be taken to close those. So story power is absolutely critical. And as I close out my section, the National Quality Forum Safe Practices for Better Healthcare are increasingly they're federal standards. They're being incorporated in the pay-for-performance methods used by the Blue Cross Blue Shield, by the Centers for Medicare and Medicaid, and they have very specific and explicit requirements for board members and for the C-suite to bring patients and families into their the quality infrastructure. There are 34 safe practices that are in 7 different areas, and woven together through this consensus-driven process that resulted in these are the guidelines and specifications that the 6 organizations that you see before you on the slide, including the Joint Commission and the Leapfrog Group, of which I'm also a co-chair. This report is able to be downloaded and printed out from the National Quality Forum Safe Practices section of the National Quality Forum. So in conclusion, story power works. Our study of the article that I showed at the beginning of my presentation of the Josie King video is a 9-minute video. It's in 2,000 hospitals. In our article called Story Power, we expressed our early research of interviews of 675 of those organizations. We've determined that the gift that my wife and I have made of the money to fund that video, it turns out, has had huge impact in terms of a life saved. A life saved for every $20 invested. So we really know, after these interviews of the hospitals, that at least the bare minimum of lives that were saved by motivating staff and leadership teams by a very simple, grainy video of a mother telling the story of the loss of her 18-year-old and 18-month-old, and then challenging the leaders of the hospital systems has had a tremendous impact. Stories work, but we need to make sure that those that we invite in to tell the stories are in the B group that I started with. We need to make sure that they've been through the stages of grief that are important to go through so that they can be active and positive contributors to your infrastructure. And most patient safety advocates realize that. I'll stop there. And it looks like I'm not able to advance the slides so that we have our next speaker up. Dr. Gladstone McDowell is a specialist with terrific training as a urologist. Dr. McDowell then did a fellow MD Anderson, where I did my medical oncology. He practiced in Austin, Texas, was one of the most compassionate physicians that anyone had ever worked with in practice, a fabulous surgeon, and then decided to go into anesthesia and undertook a pain management fellowship. He now is recognized as both a national and global leader in patient safety and in his field of pain management, and has been trained as a patient safety officer. He's going to share with you some of his experiences of the power of stories, but also some of the barriers that we've faced as we help hospitals by doing assessment of risk. And then we run into the challenges of the C-suite and the board either unable or not having the information available, and catastrophic events can occur even though all of the homework is done and we understand where the risk occurs. Dr. McDowell?
Good evening, ladies and gentlemen.
Yes.
Thank you, Dr. Denham, for the fabulous introduction there. I thought that what I would do this evening is to tell you a little bit about the power of patient stories, the influence that they have had on my practice, not only in my private practice, but also in a hospitalized setting. And the fact that I've used patient stories to make an impact where logic and reason did not work. What I'd like to do is to just sort of lay some of the background here. After my pain management fellowship, I took over the inpatient and outpatient pain management of a major medical center. I grew the practice to the outpatient practice and the inpatient practice consultation pain team. what I found was that when I took over the pain committee, I was doing some things that I thought made sense. I noticed that we had a significant component of medication errors that we had been partially successful in addressing. I made some changes to improve these. What I found really made the biggest impact was when I took the IHI Patient Safety Officer Certification course. There I learned that some of the things that I had I'd done on the pain committee were actually patient safety innovations that I didn't know about. I just did things that seemed logical. But I learned several tools and met a large number of people that I could use as a resource base to ask questions, borrow initiatives from them, and improve the safety of patient care at my hospital, but also regionally, and then went on to apply that nationally. I would at times work with our administrators, our surgeons, our primary care physicians to indicate that there were certain advances and changes and reduction of numbers of medications and force functions that we would like to initiate as a part of the Pain Management Committee recommendations. Received quite a bit of pushback on these, often because they were different. They were different than the usual culture for the institution. Some of them cost small amounts of money or larger amounts of money. What I found to be very, very impactful was to sit down with these different groups and to present stories of adverse events that occurred with patients, to present stories, or actually have nurses or pharmacists there, to present stories of frustration with the lack of support or education or lack of protocols that resulted in some type of patient harm, either from a medication error, an infection, and to do this in a very positive manner. And I found this to work a lot better than going in and simply complaining and arguing for things, which is not my nature anyway. So in an effort to make this a win-win-win, we really relied upon the use of patient stories. What we found was that a very simple thing. We had patients who were receiving OxyContin at times when they were to receive oxycodone, but they were in a similar package, actually an identical package, right next to each other in the Pyxis. And the nurses, in a hurry with short staffing, would sometimes pick up the wrong medication, and the patient would receive it. I reviewed these in the Pain Management Committee. We came up with protocols. We moved drugs. We asked companies to change colors. We did things with epidural catheters and PCA pumps. We put color-coded tags, force functions, and double checks in place. I remember speaking to nursing services and saying one of the problems that we often have in obtaining these double checks is just compliance, because the nurses will sometimes figure out a workaround to this if they're busy and borrow badges and do double checks that way. That was not well received from me when I had patients to come in or along with nurses and relate this to the powers that be. We oftentimes were much more effective. So this really pointed out the power of patient stories to me. The other thing that I found important was the importance of transparency, and this is a teachable skill that is often avoided because it's in everyone's nature to be defensive. We found that when we pushed for transparency with nurses and physicians, we had a significant improvement in our patient safety initiatives, using stories from patient harm, nursing frustration from errors because of inadequate training or inadequate protocols, really pointed out that if we communicate clearly, we use three-way repeat backs and read backs and perform effective handoffs and use SBAR techniques for effective handoffs and communication with each other, and then get everybody to sort of demonstrate their personal commitment to safety by acting in a conservative and rigorous manner in adhering to things like red rules, the STAR technique, the SBAR. We really found that we improved the efficacy of our pain management and overall nursing quality. The second thing that I wanted to just touch on was the importance of, or the impact of, the Chasing Zero documentary. I've known Dr. Denham for quite some time. I was really impacted by the story about the error with Dennis Quaid's children. I think we all love and cherish children, and we're horrified by the medical error. But having seen how it happened, we are currently in the process of completing a short essay on a similar issue with different types of needles that are commonly used within hospitals that don't have effective differentiation. I think Chasing Zero is an important video for all healthcare providers and administrators to see. I found that patients in my waiting room would indicate that they had read about this in the AARP articles. I think we all saw Dr. Denham's article that he wrote with Julie Tao. I think stories like that are very compelling. They are true. They are understandable. We can all see how things like that happen, and oftentimes you can get through to the C-suite sometimes a little bit easier than going in and being negative about things or complaining. If we go in with a positive attitude, we relate actual, true events. We bring patients, healthcare providers in to discuss their experiences and share their, sometimes their horror stories, but also their successes with implementing what they consider to be safety innovations. We can really be very, very impactful. The last thing that I wanted to discuss was the impact that we found that patient stories had in dealing with evaluations that we've done for national hospitals or organizations. I'll just tell you a brief story. We reviewed a few major medical hospital systems reviewing their pain management and anesthesia protocols, and in at least 2 instances we identified significant gaps in their systems in terms of technology and processes that were potential havens for patient safety, errors, and mistakes to be made. We actually declared the systems unsafe, evoking a great deal of defensiveness. However, everything that we try to do is in a very positive manner, trying to identify the problem and come up with solutions to cure or fix the problem and continue to reevaluate it. One of the problems with this particular hospital system was that no one could agree which cost center would take on the expense. The end result was declining to make any of the major changes. What happened after that was that they failed a JACO visit, primarily based upon some of the patient safety gaps that we identified in the pain management arena. They unfortunately went on to have a Sentinel event with significant legal ramifications, and at that point in time went back and reviewed our evaluation and realized that this was something that they did not want to spend several hundred thousands of dollars to correct, and now it potentially could cost even more, and even worse still, patients and healthcare providers were harmed. Dr. Denham and I have found that use of stories to illustrate the need to adopt the strategies of these progressive organizations and to steer people towards looking at the NQF safe practices and trying to implement these in their institutions have really helped. I think all of us need structure. All of us need standardization of practice. All of us need to look at our cultures and try to improve them. Sort of level the hierarchy, get rid of some of the egos, and try to focus on what's best for not only patients but all of our customers. And our customers are the employees, the people that take care of the patients, the people that worry about the patients, the people that worry about the finances of the institutions. And patient stories oftentimes get the point across a little bit more than simple text and what people would consider to be rational thought. So I would encourage you to look at these in your institution, identify good patient stories that have a positive message. Sometimes, unfortunately, it takes a problem to effect a change, but we don't want to only harp on the negative aspects. But if there's a negative outcome, then identify where are the problems here, go through our risk assessment, and then come up with solutions to avoid this happening, because I think we have the obligation to take care of patients and improve the care in our organizations. Chuck, I will stop there, and I'd be happy to discuss more during the Q&A question.
Great. Thank you, Dr. Young. Really appreciate it. We're really honored to have Dr. McDowell kind of share his experiences with us, as we are Dr. David Parda. Dr. Parda is the chairman of radiation oncology at West Bend Allegheny Rural. As a board, we thought that it would be a great balanced message to be able to have a practicing clinician who also has to wear the hat as a board member of a healthcare organization, just like so many that are undergoing many financial challenges and under the cost pressures and under the pressures and practice pressures and evolutionary changes that are occurring in the healthcare system, and having to wear both hats as being a leader of a multi-million-dollar clinical practice while also being a board member of a multi-billion-dollar organization that has to work within the confines of the structures of what we're running into with the changes in healthcare, run academic centers, take great care of patients, and really strike the balance between economics, clinical, operational, and financial performance. I found him to be an absolutely terrific board member, one that really understands these critical issues of culture, and I think one of the shining stars we're going to see in the future. David, do you want to share your experience as someone that is passionate for quality and high performance while at the same time having to balance the fiscal responsibilities as a board member?
Yes, thank you, Chuck. I put this first slide up that's a picture of our hospital with some of the titles, some of my jobs for this health system. And I think it really just speaks to the need for leadership in many areas at our health system and all health systems, and hopefully my ability to contribute. As Chuck said, I'm one of the 20 board members for our $2 billion health system, and there are 4 physicians on the board, so 4 out of 20 board members are doctors, and there are no other board members that have clinical or operational experience in healthcare. Most board members have a finance background. However, all board members have quite a passion for healthcare and a lot of personal and family experiences in healthcare, and a lot of ideas on how to make healthcare better. So I've been on the board for 2 years, and a big part of our focus has been to try to get the board and the decisions closer to the patient and healthcare professional level, and to really get our health system focused much more on clinical and operational activities rather than siloed off financial-based activities. And as Chuck said, we've been in a particularly strained market, and we've been very strained and constrained financially. It's a very competitive environment here. We've had a lot of financial distress in our health system. And one of the things that I had to do in a particularly capital and staff-heavily is to figure out ways of safely taking care of patients with some significant cost or constraints. One of the things that Chuck Denham and his colleagues have helped us do is to get patient stories and patient representatives more at the board level. We do have patient representatives in our quality programs at the system-wide board level as well as the hospital levels, and we also have other methodologies in place with regard to patient representatives on patient safety committees. And we have a care on call program that also allows patients, family members, and visitors a means to activate help response for unresolved issues with care, communication, or comfort in a real-time manner. So we have found that to be very helpful for filling in some of these gaps. The second slide just shows that there's 11 sites where we deliver radiation, so that can get to be a pretty complicated environment. The next one is more of a schematic where our commitment over time has been to build and integrate clinical, technical, educational, and management programs. And the key component to the management program has been operational and patient safety programs. This is a slide showing all of the equipment that needs to be integrated and used in a safe manner to treat more than 300 patients per day. And we deliver more than 50,000 radiation treatments per year with a lot of different hardware and software with all of the complexity that brings in and the potential for errors. As Chuck mentioned, there have been a lot of high-profile errors associated with radiation oncology, which is the high energy. These are high energy X-rays used mainly for the eradication of cancer, and lower energy X-rays for radiology imaging studies, mainly CT scans. So, given the cost constraints in our health system and the complexity of the work throughout multiple sites, we've really focused on integration, and we've worked on building this environment for the last 11 years, and we really have used as a backdrop for all of our work this Institute of Medicine guidance, talking about the need for us to integrate care better. And we have needed to understand better the lingo of management theory, whether it's quality, lean, Six Sigma, Toyota production, and knowing that this is only now getting incorporated into healthcare in a much more comprehensive way with the help of leaders like Dr. Denham and others. And our region has been fortunate in that the Pittsburgh Regional Healthcare Initiative and its lean improvement methodology, perfecting patient care, is something that we've been involved in, and we've all had, as leaders of our radiation oncology department, had training in. And I would say that this was a good first step, and it has helped our hospital with regard to some of the basic quality initiatives, like central line-associated bloodstream infections, etc. But it became obvious to us as a group of radiation oncology leaders, and now we're leading most of the health system's oncology initiatives, that focus on lean methodologies is not enough, and that's really when culture change and evolving from finance-based management to values and care-based management was key, and we were fortunate to then be introduced to Chuck Denham and Ann Rhodes and Care Leaders and People Inc. and much of the work that you've heard about. And this was my attempt, as I explained this to my physician colleagues and other colleagues throughout the health system, to say that we really have the opportunity to live more on the left-hand side of this slide with the care of patients and colleagues, focusing on service and professionalism and quality, safety, expertise, and operational efficiency and cost optimization, and really try to control that right side of the equation. Clearly, we need to be financially responsible and disciplined, but we need to put that in its proper place as far as the money, power, and ego goes in order to really be excellent in healthcare. So our goal has been to build a high reliability organization and a learning organization, and in a particularly finance-constrained environment and an environment that has really struggled for survival for quite a time. Safety for healthcare professionals is something that we've really had to explicitly work on, because these can be particularly politically charged environments, and a big part of our work has been to try to help make it safer for patients and healthcare professionals. So back in 2004, I thought I would relate this experience that we had with an incorrect treatment of one of our patients. And I'll quickly go through this. It's got some complicated technical aspects, but it really does speak to the fact that we have a lot of complicated processes in healthcare, and radiation is a computer-controlled environment now, and that really has to be optimized with regard to people processes. So two therapists, these are the technical people in a radiation department who deliver the radiation according to the physician's prescription. We're working on one of our linear accelerator treatment machine 8. One therapist was running the treatment machine, meaning running the computer, and the other therapist was taking the patient in the room and setting them up for treatment. The patient that was scheduled for an IMRT treatment, that stands for intensity modulated radiation therapy. It's computer-controlled radiation, where the treatment is delivered in these small volumes, voxels we call them, where you can, with greater computer control, optimize the way the dose is delivered according to that individual patient's anatomy. The patient that was scheduled for that neck treatment for neck cancer at 9:30 canceled. However, that patient was already loaded in the computer system by the therapist. When the patient did not arrive for the treatment, the therapist failed to remove the canceled patient's treatment from the computer, which is called Prime View. The 10 a.m. patient was taken in the room for the treatment, and the therapist running the Prime View, and the patient never had contact. It's our policy to verbally state the patient's name and date of birth before they go into the room, so that we make sure we pull up the right computer file. The setup therapist took the patient into the room without looking at the in-room treatment monitor to verify that the information in Prime View matched the patient to be treated in that room. At that time, we weren't completely paperless, which we are now. This was 7 years ago. The corrected paper chart was being used by the setup therapist, so the patient was set up properly for the brain treatment, but the computer program had loaded a neck treatment. This slide just shows that the treatment was then delivered, and the setup therapist was to go into the room after 4 arcs, different rotations around the patient, to then change the table position. However, 6 arcs were delivered since it was the wrong patient's treatment. And upon that, the setup therapist went in the room and moved the table as it was supposed to be done for that patient. And then the therapist on the treatment machine went into the correct patient's computer file and downloaded that and went ahead and treated the last 2 arcs associated with that table shift. the therapist that did this treatment at that point could not have possibly known could not have possibly known that they didn't use two different plans, two different treatment plans for two different patients on the same patient. So we discovered this error during weekly chart review. This shows the schedule as it appears in the computer program, and if you can see the pointer that I have at 9:30, that's the IMRT neck treatment, and at 10 o'clock is the IMRT brain treatment. The neck treatment was pulled up on the computer program, yet the brain patient was being treated. It's critical to have two therapists on each machine to minimize this, to have the pause for the cause like we do with surgery. And we really have focused a lot on that andon cord philosophy, so anyone can pull the andon cord at any time. This shows how the patient is selected. Here on the top left, you can see the patient's face that we blocked out. Many things that have to be checked before that treatment is delivered. Other aspects showing the types of treatments that are delivered, the fields that are being delivered, and how there would have been the need to return to the schedule to reselect the correct patient at 10 o'clock. And just some views of fields showing. And this was a warning that came up after treating the two IMRT arcs, because the other four arcs were not treated in the patient, and it's a warning to say that that all fields were not treated. So the action that we had to take, unfortunately, was to essentially reassess and improve our QA processes. And at this point in 2004, we realized that we didn't have a good enough culture of safety, and we still don't. You have to continually improve this. We didn't have enough of a culture where someone would just stop the treatment right then and report it. So unfortunately, the therapist that was running that treatment did not report the error and attempted to cover up the error. And this was definitively determined as we went through the computer records as well as the interviews with staff. So we feel strongly about a culture of safe reporting and learning from mistakes, and we feel strongly about not having a punitive approach to the reporting of errors, and we think of things as system failures rather than individual errors. This resulted in an employee being terminated because of the lack of reporting of the error and the attempt to cover it up, not the error itself. The therapist taken in the room was given a written warning for failure to follow the patient identification policy. Fortunately, the patient was not harmed. It was a similar dose that was delivered on a day-to-day basis, 200 centigrade in each of these patients with slightly different treatment plans. So we knew that we needed to improve our processes throughout our department, and this was reported to the Department of Environmental Protection, and we then embarked upon a several-year process to become accredited by our national organizations to further improve our quality assurance processes. We started a quality control trigger process where we wanted to get the staff members more engaged in leading these initiatives. And this is showing some of our data over the last year and a half with nearly 120,000 treatments delivered and one reportable misadministration acceptable. We are an integrated set of treatment sites and the largest accredited radiation oncology program in the country, but it takes a lot of work as a team on a daily basis to keep these patients safe, to keep our patients safe, and frankly, to keep healthcare professionals safe. If something goes wrong with the patient, it's not just a patient that's harmed, but it's many healthcare professionals that are harmed. So we have a particular opportunity in our region in Pittsburgh to really improve quality and value. And like I said, we've been in a very finance-constrained environment, but I do think those cost pressures are helpful in some ways to teach us to do more with less and to really integrate our work and work as a team.
Well, David, thank you very much. And I think you through the story about the two technologists and then having the cover-up kind of occur, this is one of those elephants that's in the room as we look at many organizations across the United States that we do have cultures that predispose many caregivers to feel that they're not in a safe environment to report an error. And almost 100% of the cases that we see across the country that float in that have some kind of a catastrophic event, after the fact, records are altered. And it may have some influence, there may be some influence by risk management, it may be caregivers, it may be someone along the chain, it may be not delivering the proper information to patients and families after an event. But this is something that has not been published broadly, but that everyone knows occurs. And then what happens as a board member or a leader is that we punish the caregiver because we say, well, this behavior is not proper, and yet we have a cultures that are so hostile and so focused on the individual person as a failure for what 95% of systems actually predispose. And that our leaders really own that. And I think in the years to come, we're going to see that our board members and our C-suite owners of these administrative systems have to bear some responsibility to create cultures where every error is celebrated as an opportunity for improvement rather than a way to find fault with someone that can be blamed, and then we move on. So thanks for illustrating that example and the caregiver example. I'd like to move, we're about 9 minutes behind, and so I'd like to give Regina Holliday full measure of her opportunity to share the power of stories and her personal experience. I will never forget hearing Regina Holliday up on a stage in front of 1,000 quality improvement organization leaders in Washington, D.C., have her share her story in such a positive fashion and in such a powerful way, connecting the head and the heart together. One of the greatest social entrepreneurs of all time, Dennis Wagner, who was running the program, was next to me, and I said, Dennis, I've really got to invite Reggie to come and really reach out across the nation to tell her story. And he said, go up on the stage, just go and talk to her. And that became the beginning of our relationship. We've appointed Reggie as a patient safety fellow with TMIT. She has a terrific background and interest in social media and is leveraging that in one of the most powerful ways I've ever seen to reach out and activate a grassroots network of patients and families to come to you as hospital leaders and to participate in a positive way with your organizations for improvement. Reggie, go ahead.
I painted at Avatar, which is a survey conference about HCAHPS data. See, I'm a patient activist, but I'm also an artist. So what I do is I listen to what people say within the dialogue and discussion about health and patients, and I paint what that means. And this painting is based upon a conference that I attended, but it's also based upon the first webinar I was on with Chuck Denham, where I kept hearing people talk about terms and things that I didn't quite understand. And when you're just listening, you're part of a new world, it's sort of confusing. So the first leap of understanding that a patient speaker often has is medicine itself, because these are terminologies and terms we aren't used to. We aren't part of this world. But then when you start speaking in front of the C-suite in the boardroom, there's a whole other set of terminology. You start learning about Lean and Six Sigma and all these things you've never heard about before. And oftentimes the dialogue is phrased in such a way as things like, let's take the deep dive, let's walk off the plank. How about we go through the sea of change and come out to the other side of the light? And all these terms are used about where's the elephant in the room and who took my cheese. And sometimes as a patient gets sort of confused about what's going on. And that's what this painting is partially about, is that when we dive into a new world that we don't know what's going on, it can be challenging and it can be scary from the provider view, the CEO's view, and from the patient's view. Next slide. This is a scale of value. On the slide before you saw I had two colors of paint. That was two types of blue that really are the same color. But when you get into scales of value, it starts with the very, very light and goes to very, very dark. And when you deal with patient stories, you're going to deal with that. Oftentimes we've been through something incredibly traumatic, and it's a question of what can we do with that and where can we take it. When you listen to Dr. Denham talk about the stages of grief, he's 100% right on. And there's a whole bunch of patient speakers out there that are stuck in one of those stages, and we've got to do everything we can to help them through that. But when they've made that leap, when they've gotten through to acceptance, oftentimes they are one of the most superb advocates you can ever have, because they're speaking from the heart, and they really, truly want to help the situation. So it's incredibly important not to turn that powerful force away. Right. When we look at data sets and bar charts and graphs, oftentimes those kinds of things can be very analytical and dry. They can be hard to understand why is what we're talking about so very important. And Dr. Denham spoke earlier about sticky and made to things that are made to stick. Patient stories are incredibly sticky. Numbers, analytics, the bar chart you saw a year ago in a room, you probably don't remember that, but you do remember Sorrel King. You do remember little Josie. Those are things that get stuck in your head and you can't get them out, and they make you want to change things. So what we want to oftentimes provide is that visual picture, that sticky memory that will allow you to go forward in front of a whole bunch of people who may not agree with you and feel empowered that you must create positive change. Next slide. Nurses' progress notes, 4/18/09 at 9 o'clock. Look, Dick. See Sally and Tim? Funny, funny Sally. Funny, funny Tim. I don't know if you know what that is from. It looks a lot like a very bizarre nurse's note. When I read through my husband's medical record and saw nurse's notes and doctor's notes that I didn't understand, that weren't complete sentences and just had a couple of phrases, it confused me just about as much as this comment. Next slide. Now if you have the full picture, now this makes sense. This is Sally, Dick, and Jane. Don't you remember those stories from when you were kids? What was really important when you were trying to learn how to read was the whole picture. It guided what was said, and it allowed for you to understand what was going on in the situation. When you allow patients to report data and make them part of the entire experience and let them tell their stories within your venue, you make that happen. You take dry data sets and incomplete records of care, and you make them complete and real and powerful. And you have the power to do this. Next slide. That is a picture of my husband. And it goes back again to that, what would a child think was right? You know, simple stuff like that Sally, Dick, and Jane primer. In this painting, you see a little child who's on top of his vintage 50s toilet with his lunch pail open. And that child looks very, very worried because he knows, even though he's only 4, you don't eat off a toilet. There's a 50s-style nurse. She's got a lunch tray, and she's getting ready to put it down on a bedside patient tray table that's covered with incontinent changing supplies. Because if you've been in a hospital and you've been a caregiver, well, you know that bedside tray table is used for bedding, changes for incontinent patients, wound care supplies, and food, and is frequently not disinfected between uses. Even when disinfected, oftentimes, if you're talking about C. diff in the spore stage, the disinfectants are not strong enough to deal with the problem. So this painting itself is trying to say, as a patient, as a child, as just a regular mom, I know something's wrong and I've got to do something to change it. Next slide. See, I was just an artist and a retail sales clerk. I was really sort of a nobody when it comes to the world of medicine. When my husband was hospitalized, he was hospitalized for 5 weeks in 11 facilities. And we saw so many things go wrong. We saw radiation, we saw infection, we saw improper catheter care. We saw it all. My husband was first hospitalized. It was just for tests. We just thought he had just a problem with his back, right? So he went in, and I went back to work, and an oncologist had just been in the room, the one who'd given him the test. Said that he had tumors and growths in his abdomen and a 3-centimeter tumor in his kidney. And God, please come as soon as possible because he was so scared. So I left work and I got there as soon as I could. And by the time I got there, the oncologist in charge of my husband's case had left town. And he would be gone for the next 4 days and would not answer the cell phone nor would respond to email. So I scurried around the hospital just trying to find out what was the status of my husband's care. No one would give us direct answers, and even though this is an electronic medical record hospital and everything was in a computer system, no one would let us see the medical record. After 4 days, an on-call doctor came into the room, and we sat there patiently waiting for her to say something about the other tests. You know, he had a PET scan and a bone scan. What were the results? She didn't say anything. She just looked at the dilaudid pump. And we finally said, well, what were the results of the other tests? She looked at us and said, you mean nobody's told you? Like, no one's told us. How far is it? And she said, yes. Yeah, it's everywhere. It's in his lungs and it's in his bones. That night I got on the internet and I researched my husband's case and determined that my husband had stage 4 kidney cancer. The likelihood of surviving more than a few months was very good. Then the oncologist came back in town from his conference. He went to my husband and said, I understand your wife's been asking questions about this case. I said, yes. The doctor said, well, if little Miss A-type personality has questions, she needs to come to my office hours. And I did. When I got there, this is the painting of that day. Because he never closed the door. He never stopped answering phone calls. He never turned the computer toward my face so I could see. He didn't stop talking to the nurses about the employee parking lot problems and the fact that somebody was taking the wrong space. He talked about Miss Rosen's chemotherapy transfer later in the day and how they needed to get a suite ready. This was the time that I had to spend with him. As I asked him to list the Mets, he started speaking so fast and I couldn't understand all the words. I asked him to please slow down because I had to write all this down because I researched it at home on the internet. He said, well, I don't like patients who research on the internet. But I understand, but I don't have a background in medicine, so this is my only way to research and understand what you're talking about. But that's right. I have the medical degree. If you look at this painting, you'll see on the wall there's a medical degree. And there's a family picture. That's his family. His family when he's tearing our family apart. Fred was a good patient. He didn't make waves and he didn't complain. After a few weeks of not having access to information, I went down to medical records and I asked for a copy of my husband's entire medical record. I was told it would be 73 cents per page and a 21-day wait. The very next day, the doctor came in our room and said he was just going to send us home on a PCA pump. Just going to send us home to die. 3 weeks after going in the hospital for back pain. I fought for 5 days to get him transferred to another facility, and we were transferred with an incomplete and out-of-date medical record and transfer summary, which meant when my husband was transferred, they could not provide care. We laid in a bed for 6 hours in excruciating pain while I tried to cobble together a medical record using a phone and a fax machine. Next slide. In the world of customer service, there are things called onion letters. That's where you complain about someplace. And there are things called orchid letters. That's where you write all the good things that happen. You really need both. I know it's really fun to have that orchid letter and to frame it and to put it into the waiting room and show everybody in the world what a great hospital you are. But you know that onion letter? That's just as important. Because that letter can save lives. There is no better letter that you possibly can get than somebody who complains about something that's wrong. Because this is a beautiful gift this person has given you. The gift to change everything. Slide. Don't discount anybody. There's always amazing people in your life that can fix things, that can help you make your hospital better. If you look at this painting, there's a woman, and she's elderly. I think she's like 83 or 84. You might not think she's going to have a lot to say, but if you talk to the folks in Green Bay, Wisconsin at Bell and Health, they can tell you about an amazing woman named Betty Bundy, who at the age of 84, when she was called about how did she feel, she was treated at that hospital after her stroke care, She told them, well, it sucked. And they took her so seriously. They have used her on every patient panel, and she's part of their electronic medical record rollout, and they named it after her. Their rollout of their new system is called Betty, because they want to ask every time they do anything, what would Betty do? Slide. I had the honor with Chuck of being at the Partnership for Patients kickoff meeting just a couple of weeks ago, and I was the patient in the room, and I set up a canvas and I painted this picture, and it was a revisioning of the logo of Partnership for Patients. The major thing I changed within that logo is if you look at the original design, the doctor's doing everything. He's touching the patient, he's taking the pulse. The patient is not that involved. But in my painting, you'll see the patient's holding the doctor. And the patient is on Twitter, and they're tweeting the appointment. I also had the honor of talking with Don Berwick at that event, tell him how important it was what he was doing for patient safety, and how much all of us patients out there cared for him. See, when you involve a patient in the conversation, you bring in their skill set and their vision. So we might take all the people who work at Health and Human Services and put them in a diner and pretend they're pouring us coffee, because that might be where we come from. But it doesn't mean it's not as important as what's going on in government and going on in hospitals. Why? When you invite a patient to join the conversation, you change absolutely everything. You open a door to a brand new day, a beautiful sunrise on the horizon. You give us the opportunity to tell our story, and through that, make life better for others. We can make it better for others. Next slide. You see, it's almost like we're all on a playground, right? And we all want to play. We all want to be part of the game. But if we see the doctor off to the side with the headphones and the hula hoop and not paying attention to us, we're going to feel so alone and not part of the solution. You have the opportunity to change this. Next slide. And there are tools out there. Like I mentioned Twitter earlier in this call, there's Facebook, there's SlideShare, there's Flickr, there's all kinds of wonderful social media tools that we will use to communicate with you. Join the conversation, because I will tell you, even if you don't join, we are still talking. And we will talk all over the United States about our care until we get change, and that change be a positive thing. Fine. You see, what we're talking about between patients and doctors and providers, insurance and electronic medical companies, is building bridges. And when we build those bridges, we connect silos of thought, and we help all of us have better care outcomes. Fine. And when we build bridges, it's amazing the picture that happens. Remember Betty Bundy that I spoke about earlier? That's a picture of her, and she's quilting a quilt of all of our care and what it means to us. Next slide. You see, when you invite the care moms and the care dads, when you invite the people in your life who see these things happen, who are the patients or caregivers, when we get to tell our stories, we change things. And it helps you out, it helps out the system and how you take care of individuals, but it also helps us out emotionally and physically. This is my vision of us all working together. This is a health information exchange. This is if the vendors and the providers, if doctors and patients all were popping a parachute up in the air with balls bouncing happily. See, this game doesn't work unless everybody holds a handle. And parachutes, they're so fun to play with. But, they also save lives. And that's what we're talking about here. Thank you so much for your time today.
Thank you, Reggie, for your gifts and bringing your gifts to the to patient safety and quality. And one of the most important things to recognize is that when patients and family members Reggie come to us and share their stories and have to relive their stories, it takes an amazing amount of courage. We've worked with patient advocates for years and years, and it isn't easy to go through this emotional experience, and they do it as a gift for us. I'd like to open things up for questions. What I want to do, I've got a couple of questions here that folks have sent in to me. Dr. Parda, as a board member, was there fear to bring patient stories to your board meetings, and how did you all overcome that at West Meadow Allegheny?
I think there was, Chuck, because like what was discussed, there is a worry that the overall well-being of the health system and the institution will be diminished. And like I said, we've been in a particularly precarious financial situation, so that any kind of indication in a particularly harshly and negatively competitive environment here, can be used to further harm the institution. But in the context of putting the patient first and just thinking along the lines that we have to improve our hospital performance, the board and the patient safety committees agreed to do this and try to make it as transparent as possible, and with some coverage and some help from you and other leaders. I mean, you mentioned the story of Sorrel King, that occurring at Johns Hopkins Hospital, known to be one of the better hospitals, and it is helpful knowing that these mistakes occur everywhere, that it can't be used as vigorously against you. So that's the tack that's the orientation that our board has had.
I know your leadership team asked at one point what to do about a caregiver that was a nurse that brought home medical records in her pocket because she wanted to make sure she had wanted to make sure to get the right data entry in the electronic medical record, and unfortunately had copies of records in her pocket, and they had fallen out, and a local neighbor found them kind of pasted up against a fence where the wind had blown these. And the first thought was to fire the nurse for taking medical records home, but your organization, instead of doing that, made that nurse then an expert on helping other nurses recognize how to do data entry and prevent such a breach in medical privacy. And I think that those stories, those are also the kinds of stories that can have great power in dynamically changing a culture when we do the opposite of terminating someone and actually getting them to be part of the solution. Reggie, can you give us a little bit more perspective as to how many patients and family advocates are out there interested in getting involved with their hospitals? And just for time, I also want to embed, before we ask you that, the fact that as we've been studying bringing patients and families into organizations, we find organizations like Dana-Farber, where after a bad event, they brought patients and families into virtually every committee and administrative leadership initiative, and since that point in time have had no lawsuits. So I think as we think about this risk and bringing in these advocates, there also is the counterintuitive phenomenon that it actually reduces risk with the transparency. But coming back to Reggie, do you think that there are ready and able patient advocates and champions across the country that can meet the need that now is being established to bring them into the quality infrastructure of hospitals?
Oh, yes, Chuck. There's an amazing resources available out there for you. There's Tricia Torrey's Advocate Connection, which she connects you with people who are patient advocates. That's their profession, actually. And then there are individuals like myself who speak about national health policy and how we can change things better for hospitals throughout the nation. There's folks like ePatient Dave. A lot of us are out on Facebook and Twitter, so you might want to consider using those social media tools. On Facebook, you find a lot of us under the IHI Patient Activist page. On Twitter, there's hashtags like Patient Safety, where a lot of us will tweet on. There's also the Society of Participatory Medicine. That organization teams patients with doctors and other providers in ways to create better data transparency and care transparency and patient-centered care. So there's amazing tools that are out there so you can get connected with people who are speaking nationally on this subject. But then there's amazing people right there in your local community. When I visited Bellin Health in Green Bay, Wisconsin, I was really astounded. They had included patients on every level of the facility and the workflows for the EMR rollout. They were using them constantly, and they found them in their local community by basically either doing surveys or outreach. They use a Facebook page. There are people in the neighborhood who want to do this. Nationally, there's a major push right now. A lot of hospitals now have patient advisory councils. They're being added to boards. So there's a lot of people out there very, very interested. The major thing I would say is really make sure that you have a diverse group showing all different levels of the economic strata of your area, also showing lots of different ages and ethnic diversity as well, just to make sure that you don't just get one pool of one type of thinker. It's very key to get a lot of different voices because each one of them adds to the solution.
Chuck, this is Dave Porta. I wanted to just follow up on that not terminating healthcare professionals for making mistakes is key to reducing harm for both patients and healthcare professionals. And the reason that I highlighted the circumstance is that the patient error that I described forced us to examine ourselves as department leaders and our employees. And the first point was that the patient error was a failure on our part as leaders of patient care in our department. And the second is that not reporting an error or covering up an error is something that we consider to be a never event and our cause for terminating any of our employment, including any doctor in our department. So I just wanted to make that point. This is, I don't highlight that circumstance relative to a punitive action. I highlighted as to a failure on both sides and us having to take an action that was particularly unpleasant for us and not something that we wanted to do. So we've worked hard over the past 7 years to prevent those types of things from happening.
And I wanted to add one element. We just got a tweet from Cascadia on Twitter, who's an amazing patient advocate on the West Coast. She's named Sherry Reynolds. Consumers Advancing Patient Safety is a good resource, and they are available online. So that's Consumers Advancing Patient Safety, another resource for you.
One question that is
Dr. Carter, Gladstone, I absolutely support what you said about the whole transparency and not assigning blame but fixing the problem. I think it's important that we realize that is important in physician offices, ambulatory surgery centers, treatment facilities, and not only hospitals. And we need to get that message out because there's still a lot of that defensive, protective behavior there rather than really being transparent. By the comment, Regina, is that I absolutely love everything that you said. You're very inspiring, and I really enjoy your paintings. I have to tell you, your last slide about bouncing all the balls in that blanket. I was at a think tank with a lot of very smart people, a lot of national leaders, and I made a fool by getting up and saying, I have an idea. If all physicians, all hospitals, all treatment centers were on the same electronic medical record, it would make the transfer of information seamless and decrease errors. And I'd like to encourage a push for that. And I inquired where we were with that and if any of the people in the administration or big organizations were supportive of that. And there was a quite pregnant pause, and then they said, "Okay, any other questions?" So I think, I think. Well, the problem is that there are many electronic medical records out there. GE has one, Epic has one. Lots of people are highly invested in this technology, and they sell. And for them to all combine would mean that jobs are lost. But I strongly think that we need one electronic medical record that hospitals and physicians are on, because this is 2011. There's no reason that we can't do it, but I think that somebody in the government or some national organization really needs to push for that. And I love the fact that we just need to fix that. There's no sense you filling out the same information in my office that you filled out yesterday in your primary care physician's office who sent you over, you know.
But also,
thank you, Gladstone. Real quick, just to come back on a couple of quick questions, and then back to you, Regina. But one is for boards and hospital leadership teams that want to get started with using stories to motivate and to start focus on attention. I just wanted to give one example of what one organization has done. Marty Heldorfer, a former father, a person of the cloth, was involved in the exemplar healthcare system and decided at a Christmas board meeting to identify how many people's lives had been saved by their patient safety initiatives. And in so doing, identified patient faces that could be and names that could be put on medallions that each of the board members could put on a tree of life as a symbolic gesture. And what this did to the board was it put faces, as the title of this webinar is to put a face on patient safety. This put real people's faces in front of the board to recognize and acknowledge the lives that were saved by their safety organization that they had within their own administration. The patient pictures have a powerful way of bringing the personalities and the fact that there are families just like each of ours that we're responsible for as board members, and it takes us away from just looking at cold statistics and really looking at the powerful impact that can be seen. The second question is, how do you get started to get a patient advocate board or a patient advisory board started with our hospital? And Sue Sheridan, one of our wonderful patient safety advocates, who you can look up on Google and you see as a speaker on www.safetyleaders.org, and who was in the Chasing Zero movie, actually went back to the hospital where her son now has permanent disability due to an adverse event that occurred, and teamed up with her own hospital to say, let's work together positively going forward. And they've embarked on setting the stage for becoming a role model of getting patient advocates involved in their programs. They took trips to Dana-Farber, to the Mayo Clinic, and to other organizations to see how their programs in their infancy or a mature program like Dana-Farber had been undertaken. And so there'll be more in the literature. However, just site visits of organizations that have incorporated patients and families are a very powerful way to get started and realize that it isn't that great a risk. If one carefully selects patients and family members to be in the B group that I mentioned earlier, they can have a huge impact and a positive impact, and there is a way to get started. And the 10th scope of work the federal government has for the QIOs and the emphasis on involving patients and families is a reality. Reggie, did you have some closing comments? And Christy Fuller, is it okay we've run 5 minutes over?
Yes, absolutely. Reggie, go ahead, and then I'll say a couple closing words.
Well, this was just spectacularly amazing, and I did want to throw out there I have an arts background, but a business background as well. And a lot of the talk, when we talk about electronic medical records and having them communicate between different venues, this is already being solved in business. So like if you run a bookstore, for instance, you can trade information back and forth between many, many bookstores using many, many different POS systems. They just have been designed to work together. Guess what? We can do the same thing in medicine. So it's a matter of all of us coming to the table, all of us joining in. Really, when we do a call like this, we should have a member of every part of the care continuum, because it just changes everything. So that's a major takeaway that I'd love to leave this call with, is involve patients, involve vendors, involve doctors, involve providers, involve CEOs. Get us all talking together. It will change the world.
And yeah. Chuck, if I could say that the faces and the stories are the key, because my experience in the last 2 years on our board would be that even though we're fairly advanced as far as patient safety initiatives and we have patient representatives and advocates, the activity is still very far removed from the point of patient care, and those stories and those faces are key. And you just have to do that to get closer to the point of patient care. I can tell you that our boardroom just seems very far from the point of patient care, despite some decent patient safety work.
Christy?
Yes, well, Dr. Denham and Dr. Parda, Dr. McDowell, and Reggie, I can't thank you enough for sharing these very compelling thoughts and stories. It's just been phenomenal to hear you speak and to just share your thoughts with us. Thank you so much for taking time out of your very busy schedules to share with us. I would like to just say for those on the phone that within each of our states, as the Quality Improvement Organization, we will be asking hospitals, nursing homes, physicians, pharmacists, business offices, and others to work with us in their communities on this Partnership for Patients initiative that Chuck had mentioned earlier. And they have bold goals to decrease hospital-acquired infections by 40% and reduce unnecessary readmissions by 20%. So we will be in touch with these healthcare communities within our states, working on these goals and including patients in every meeting. That's one of the mottos, is that there's a patient in every room. And so that is one of our goals as we move forward into the 10th scope of work and the Partnership for Patients initiative. So I do thank everyone again and remind people to fill out the polling questions on the right side of your WebEx screen. And unless there's further comments, I think we will close for now.
It's been a real honor. We wish you all well.
Thank you very much. We appreciate it.